All right, 12:04 now, and we're recording. We have about 10 people on the line, but that also includes a very large group from UCI and a large group from Oakland as well. So I think we can go ahead and kick things off if you'd like, Susan, and then from there, we can get moving on the whole group. So first off, my name is Michael Rowland. I work with the Pacific Sickle Cell Regional Collaborative. We have been running these talks, these Project Echo-based talks for almost 2 years now. We do a myriad of different talks. It's a lifespan Project Echo, so we run educational talks that start with some case presentation, although absolutely no PHI is included, so please don't speak of PHI if you have any questions. In the process, we also do a didactic. That's the second half of the talk. Today we have two wonderful presenters with us, Dr. Susan Klaster and Dr. Minha Tran. We are really excited to be plugging into the new conference with University of California, Irvine, and with a large group of providers training at Oakland Children's Hospital. So with that, I think, Susan, we now have 11 people on the line. I think I'll...
Right.
You want me to go ahead and share screen? Are you ready to share slides?
Yeah, that's fine. Hopefully this will work. Okay. Oops. Wait a minute. I lost you. Hold on. I don't have the slides in front of me.
See if it loads.
Something happened.
How about now? Do you see it now?
Not really. Wait a minute. Let me see if I can. Oh gosh. This isn't working.
Let's see. Can anyone else see the slides?
I can see them.
Yeah, I can see them.
That's the weirdest thing.
Yeah,
I can see them.
Okay.
Oh, here now. Oh, wait. Okay, I've got them.
Okay. All right,
okay.
Great.
Okay, let's do this before I lose them again. Thank you all for joining this call. I'm happy that we have Minha, who's the director of the Transfusion Medicine Service at UCI, and my former UCI colleagues in the room. And today's talk is going to be about how to avoid transfusions in sickle cell patients that aren't needed. And this is a talk that is primarily directed at non-hematologists, but thank you for all the hematologists that are listening. So next slide. So as you know, many of you know, we started a clinic at Martin Luther King in South LA about a year and 3/4 ago. And we've seen 36 patients. And of those 36 patients, we've had 5 patients, which is not a trivial number, that are so iron overloaded that they're, on death's door. And none of them were on a chronic transfusion program. None of them were even in care. They were all people who had continually going to the emergency room because they don't have a good provider. And every time they would go to the emergency room, somebody would inappropriately transfuse them. And I have just, I'm going to tell you a very shocking case, but it's a theme that's happening in our clinic and other places all over the country. And a lot of it is because they don't have good outpatient follow-up. They're just doing episodic care at an emergency room. But it's really important to understand when you should and should not transfuse patients in the inpatient setting so we can avoid iron overload. I'm going to go over some other, I want to ask, anybody have any questions at this point on these two cases? Mike, no questions? Okay.
Coming in right now.
Okay. So in 2014, ASH started this campaign called Choosing Wisely, and they did a whole thing on sickle cell. I believe they've updated it, but basically what they said was don't routinely transfuse patients with sickle cell disease for uncomplicated anemia or uncomplicated pain crisis without an appropriate clinical indication. So that, and we can talk about that, but there's no evidence that transfusion improves pain episodes or shortens pain episodes. Patients with sickle cell who might be running hemoglobins of 7 to 8 will drop their hemoglobin if you give them a lot of fluids. But they're tolerant of that anemia, and it's not an indication for transfusion. And as we showed you in these first two cases, iron overload and delayed transfusion reactions can be the result of inappropriate transfusions, and they can be life-threatening. It's not a joke. Next slide. So let's go over the indications for What's appropriate? When is it appropriate to transfuse? So, I mean, symptomatic anemia, which to my mind means not the patient's symptomatic, not the provider. So, if your patient's got a hemoglobin of 5 and they're tachycardic and short of breath, okay, I get it. But if they just drop their hemoglobin a gram because you gave them fluids and their retic count is good, they should not be transfused. It's not, but this happens all the time in community hospitals, in all sorts of places. Definitely indicated to prevent strokes in children and also adults. Acute chest with hypoxia is an indication. And then preoperatively, anybody who's getting general anesthesia, and also we do it for some eye surgeries. Okay, next slide. So this is a study from the pre-op transfusion study that was done in the 90s with Elliot Baczynski and the group in Oakland. If you look at group C, you can see that non-transfusion, these are patients who had cold cystectomies. No transfusion, those patients had a 32% incidence of a sickling related event post-op. So it's extremely important that we give a unit or two before surgery to prevent post-surgical acute chest or pain. Okay, next. When is it probably indicated? So these are kind of questionable indications. Complicated pregnancy. I am one of these people that likes to transfuse for pregnancy. I've had a number of patients in my career who have come to me and said, you know, at 6 months I lost the baby. Those patients need to be transfused through their pregnancy. They will do well. Severe right upper quadrant syndrome with extreme hyperbilirubinemia. I'm not sure there's any data that shows that this works, but and that's a very bad syndrome to have. Refractory leg ulcers, you can try it. Sometimes it works, sometimes it doesn't. Refractory and prolonged painful episodes. I don't do it acutely in the hospital, but I do tend to if someone's having a lot of pain and their whole life is being interrupted and they, for some reason, are not taking hydroxyurea, sometimes I will do 6 months of transfusions just to give them a break. Prolonged priapism, it does work, but it must be given early in the episode. Next. Not indicated, raising the usual hemoglobin concentration, an uncomplicated vaso-occlusive episode, uncomplicated pregnancy, and minor surgery. Okay, next slide. So here's the guidelines that I use for transfusion. Don't increase the hemoglobin greater than 11 because there's a risk of CNS events. That's been documented in the literature. Don't transfuse for pain crisis, solely for pain crisis. Don't transfuse for a decrease in hemoglobin below the baseline if the patient has a good retic count, no cardiac compromise, and especially if no other severe complications. Patients admitted for vaso-occlusion can have temporary marrow suppression or also getting, so the temporary marrow suppression can just be from the severe inflammation or the viral illness that precipitated the crisis, and they will drop their hemoglobins and their retic counts, you know, temporarily, but it doesn't, if they're not symptomatic, we don't have to transfuse them. And then you should consider exchange transfusion for patients with high hemoglobins or who are critically ill. The goal is a hemoglobin of 10 to 11 and a percent sickle less than 30. I think I'll stop and see if there's any questions at this point. Nope. Anybody, Mike? Nope. Okay. Okay, next slide. So I'm going to talk.
Sorry, we have a question real quick at UCI.
Oh, okay.
Yeah, sorry. Is there any lower threshold for hemoglobin? We usually transfuse here at like any hemoglobin below 7.
That you shouldn't use that number. That's exactly what I'm talking about. What if that patient has a hemoglobin that runs 7.5 chronically and they go to 7? That's not an indication for transfusion.
What about?
There's no magic number. Some patients run at 6.
Oh, okay.
You have to look at the patient and then decide if you have to do it.
Okay, thank you.
You want to make a comment?
Yeah, I agree with Susan. You have patients, I think that's where it's really useful to have prior records and data from their previous, kind of knowing what their baseline is. So some folks run a lower hemoglobin level than you might expect. And a lot of patients who have you know, what looks like a profound anemia, they're also young a lot of times, so they have a good cardiovascular reserve, and they can generally tolerate the lower hemoglobins, and they're used to the lower hemoglobins. So yeah, I would try to stay away from simply transfusing a number and try to take the entirety of the clinical scenario into consideration.
So let me just say one other thing. If that patient who has a hemoglobin of 7 has a severe has acute chest or is very febrile or something, then you should do transfusing them. But just for the number alone, the answer is no. Does anybody else have any more questions? Nope. Okay. Okay, so I'm going to talk about iron overload, and then Min's going to talk about delayed transfusion reaction. So how quickly do patients get iron overloaded? 1 unit of blood contains 200 or 250 milligrams of iron. So 2 to 4 units a month, which is what we do for chronic transfusion programs, gives you about a half to one gram of iron per month. And after 3 to 6 months of monthly transfusions, you've doubled the total body iron burden. And there is no mechanism to remove the excess iron. Women who have menses have a little bit of blood loss, but it's really doesn't overcome the enormous amount you get from chronic transfusions. So 10 to 20 transfusions can result in significant iron overload. Next slide. Okay, how do you make the diagnosis? Well, at UCI and at CIBD, we have the MRI, which is very helpful. Some places don't have that. Where I work at MLK, we don't have that. So you cannot use a ferritin because it's an acute phase reactant. And inflammation in sickle cell increases the levels of ferritin, and it's also elevated in liver disease. So what I've been using as a surrogate is an iron panel with a % saturation. It's not really, you can use the ferritin to trend, but an accurate diagnosis really requires the MRI. Liver biopsy we don't do anymore because it's invasive and it's inaccurate because it's spotty. So it depends where you take the biopsy from, whereas the MRI looks at the whole liver. So, but I mean, I just, we have people with ferritins of 10,000 in our sickle cell clinics. So that ferritin's not really helpful, although I do have people who are trending down and then I feel better about it. Okay, next slide. What are the consequences of iron overload? Well, you get liver disease, elevated LFTs, hepatoma in the thalassemia population. People are dying of hepatomas if they're not carefully monitored because the iron is an irritant and it can cause a malignancy. Very common is endocrine dysfunction, diabetes, gonadal failure, thyroid and adrenal. Patients who are iron overload, especially not so much in the sickle cell population, but more in the thalassemia population, they get cardiac iron, and that causes restrictive disease. We have had some sickle cell patients get this. They present with cardiac failure and arrhythmias, and that's what kills them. The other thing that can kill them is Yersinia enterocolytica, because Yersinia enterocolytica is an iron-loving organism, and it can. So if you have an iron overloaded patient with diarrhea and abdominal pain and fever, you have to think about this. Next slide. This is an old slide, obviously, but it shows that once you get, it's made for the thalassemia population, but once you get over an iron concentration of about 10 in your liver, you have a moderate to severe iron overload, and you're at risk for cardiac disease and early death. So we don't want that to happen. Okay, next slide. So using the liver for iron assessment, you can see this is a normal liver, I believe on A, and then the darker one on the B side is a patient with iron overload, and that's how they do. So the liver iron, the higher the number, the worse you are. It's the opposite in cardiac. So let's look at the next slide. The cardiac, I believe this is the septum, but just so you know the way this works, these numbers aren't exactly what we get in a reading, but as the number should be 20 or higher, and as the number drops, the more iron you have, and anybody with 10 or less is in big trouble. Okay, and sickle cell patients tend to have less cardiac iron loading than most the other chronically transfused patients. I'm not really sure why. If somebody has an answer for that, I'd love to hear it. Next slide. So this is another kind of old slide. We have 3 Good chelators to use. The one that we're using on the right, ICL 670, is Jade or XJade. That's the most popular chelator right now. It's big. It's oral. The XJade form had some detergent or something in it to disperse it, and it made people really ill. So they reformulated it as Jade. The biggest issue with Jade is it causes renal problems. That's the one thing I've seen more than anything else. So you have to monitor. You can't just give them the Jade and have them come back in 3 months. They have to be monitored for proteinuria, creatinine, and then we always monitor their ferritin. But it's much easier to take. Sometimes we split the dose so it doesn't bother people so much. The formula on the left, desferoxamine, which is Desferol, we still have, I believe there's a shortage of generic Desferol. I'm not sure what's happened with that. That actually has to be done parenterally because it has a very short half-life. It's a very good chelator. And for those people who work in the hospital, I'm going to give you a slide presentation on this later, but it's a good thing to, if you know somebody's iron overloaded and they're in for a sickle cell vaso-occlusive episode or something else, you can just start the Desferol in the hospital and give them some chelation while they're sitting there. And that actually helps a lot because there are people who just are really non-compliant. So we'll talk about that in a minute. Defiraprone or Feraprox is the newer formulation that we have. That's the middle one. That is a very different drug. It's very good for cardiac iron. You have to take it 3 times a day. There are some GI upsets with it. And the biggest issue is neutropenia or agranulocytosis, which can just appear at any time. And the label says you're supposed to get CBCs every week on these patients, and that's impossible to do. So most of our patients who are on this are the ones that are transfused. So we get their CBCs every 3 weeks. We tell them that if they get a sore throat or a fever, they must immediately stop the drug and go to an emergency room. I haven't seen agranulocytosis, but I think other people have. It happens, and it's not like the first 6 months. It can happen at any time. Okay, next slide. So let me talk about how to use Desferol. So, I've done this. It just means you have to have a dedicated IV. It's contraindicated in renal failure. You have to decrease the dose in renal insufficiency. We actually do this if somebody's in cardiac failure. This is the drug to give them, and we have to do it through a PICC line or a port, or we have to hospitalize them. You give it 24/7. It's 50 milligrams per kilogram per day, somewhere between 3 to 5 grams a day over 24 hours, and it works great. But it's, for people who are outpatients, it has to be given through an intravenous access, and it's a pump. This is the drug we had before we had the oral chelators. And people had to inject it in their subcutaneously in their bellies all night long for 12 hours. And it was very hard to get people to do this. So we're grateful that we have the oral chelators, but this actually still has some uses. Next slide. So this is another old slide from the Bay Area, which I kept, but just to point out that this is going to introduce Min's talk. Most of the donors who give blood are white. And that really hasn't changed unless Min has new data, but I think this is the way it works basically in the over, at least from what I understand. The black donors aren't that common, and so most of the donors are white, and Min can talk about what that means for transfusing a patient. Next slide. All right, so Min, one could give Min the floor and have him talk about delayed hemolytic transfusion reactions.
Sure, so delayed hemolytic transfusion reactions occur in about 3 to 7% of sickle cell patients.
Whoops, looks like we've...
Immunization. Can you hear me?
Yeah.
We're having trouble hearing you.
Bit of a hiccup on your signal.
Okay, is that better?
There you go. Yeah.
Okay, sorry about that. So delayed hemolytic transfusion reactions in sickle cell are generally not due to primary alloimmunization. So what does that mean? So if a patient is transfusion naive, they've never been transfused before, and then they get transfused, they are at risk of forming red cell-directed alloantibodies against antigens they do not themselves express. So a primary alloimmunization event may take about 10 to 14 days to manifest, whereas if a patient has previously been transfused and they have the capacity to make red cell-directed antibodies, and they are rechallenged during subsequent transfusions, an anamnestic response can occur, and maybe within 1 to 7 days, they can start hemolyzing as a result. The key thing here is that about 37 to 51% of alloantibodies, especially in the sickle cell population, have a quality of evanescence, meaning they can come and they can be detectable for a period of time, and then they can fall below the level of serologic detection. So if your sickle cell patient is always transfused at the same place,
Whoops.
We lost you.
there are bloody records. Okay. Am I, because I'm showing a full internet connection, I'm not sure where else to go. Is this any better?
Yeah, sorry, we've had just 2 cutouts. That's
okay.
Right there.
That's not good. Okay, okay, this is better than I'll say here. All right, so again, just in case it cut out, about half of the antibodies are evanescent, meaning you get detectability of the antibody at some period of time after it first forms, but then the level drops below that of serologic detection. So then that can put the patient at risk for a hemolytic event. Okay, so patients who are on a regular transfusion schedule program, they are getting antibody screens on a regular basis, so you're less likely to miss emerging alloimmunization. It's those patients who are sporadically transfused who are at the highest risk of a delayed hemolytic transfusion reaction. So obtaining prior transfusion history is critical. Okay, so let me give you an anecdote. When I was a fellow, I happened where I was training, there was an infusion center, and there was a woman that presented to have transfusion, and she was a sickle cell patient, and what happened was nobody was around to consent her. So they were looking for a fellow so it was me, it came down to me. So I went up to consent her, and I don't know why I asked her this question. I said, well, have you ever been transfused? She goes, well, actually I have. And I said, well, where were you last transfused? She goes, oh, I was last transfused at such and such place about, 4.5 months ago. I said, oh, really? Okay. So then I go down to the blood bank, and it's the first time we had ever seen her blood. She has a negative antibody screen. So I say, hey guys, just for kicks, do you mind calling such and such center? This patient was transfused there X number of months ago, and just check. And sure enough, they had on record an anti-big C. So had we not kind of closed the loop like that, we could have ended up giving her anti-big C positive unit because we had no record of that, and it wasn't showing at the time because of this evanescent nature of alloantibodies. Next slide. Next slide. So,
right there?
Yeah. So,
okay.
So awareness of a delayed hemolytic transfusion reaction as it's occurring, it may not be that apparent, right? Because a delayed hemolytic transfusion reaction may have similar symptoms as a vaso-occlusive crisis. And maybe somebody might think, well, maybe the patient's having their standard, pain syndrome. The delayed hemolytic transfusion reaction may instigate a pain crisis in that patient. And oftentimes, depending on the time frame, the immunohematology findings may be negative. So we may think that, oh, it's just the standard run-of-the-mill pain crisis, and and this is where Susan's talk comes into play. Is we may be tempted to transfuse the person, thinking that we may help them feel better. But remember, there's no evidence that transfusion shortens the course of a standard vaso-occlusive crisis. So this is where, especially in the sporadically transfused patient, they are now at high risk for having a delayed hemolytic transfusion reaction, especially if they're not regularly transfused. And as it turns out, transfusions delivered in the acute setting confer the highest risk of delayed hemolytic transfusion reactions, as opposed to those delivered on a routine, standing basis, right? And it probably has to do with a heightened inflammatory state. So in a sickle cell patient presenting with acute sickle cell pain, please get history, assess for recent transfusions. If they've been transfused, especially in the last 3 to 4 weeks, then it may actually be a delayed hemolytic transfusion reaction you're dealing with. And one clue would be that their hemoglobin is now lower than it was when they were discharged from the last place. And you may want to make sure you inform the blood bank so that they can call the blood bank at the last place and get the transfusion history and figure out what they may have found, and they can do extra tests and so on and so forth. Let me tell you another anecdote. When I was a fellow, we had a sickle cell patient admitted, and this patient was hemolyzing, was getting transfusions, was hemolyzing to beat the band. And so I went up to interview the patient, and I was looking, this was back in the day of paper charts, and I saw in the history and physical from the team that had admitted her, right there in the past medical history, it says, oh, Mrs. So-and-so has a history of regular transfusions in the past, including a history of red cell-directed antibodies and history of transfusion reactions. Oh my God, how this history never made its way to the blood bank or never triggered anything was a really kind of a sad thing. So it was a tough discussion to have subsequently with the patient, but there you go. So the history is really important. Next slide, please.
Do you want to go
Okay,
another slide?
so although so we did have, so there was a number of studies that were done in the past looking at preemptively or prophylactically phenotype matching red cells for sickle cell patients who had not yet become alloimmunized. So the idea is if you avoid giving antigen positive units to a patient whose red cell phenotype is negative for those antigens, maybe you could reduce the risk that they could form or develop alloimmunization. So this gets back to the slide that Susan had earlier about the difference between what is the donor population and what is the patient population. And many of the blood bank antigens that are on the surface of red cells are ethnically separated. So depending on what a donor's derivation is, they may have a different phenotype than potentially what the phenotype of the patient population is. Okay, so there have been publications here and there about trying to get to better match the donor and recipient population. But the problem is, even when attempts have been made to do that, as it turns out, the Rh gene has a significant degree of allelic heterogeneity. So what can happen is, even though you may think you're matching for Rh and Kel, you're actually getting so much heterogeneity that you end up with antibodies in the Rh system that may even be harder to match for. And so it's a little bit of a double-edged sword. So the recommendations currently is if you have a patient who is sporadically transfused, a sickle cell patient who doesn't get is not on a routine transfusion schedule, that they should probably have a routine assessment for new antibodies 2 to 3 months after each transfusion. That way you can catch potentially, or you increase your likelihood of catching an evanescent antibody such that it's there and it's documented before it sort of dips below the level of detection. And go ahead. Okay, so this is just to show what one of these delayed hemolytic transfusions might look like. This is a hemoglobin S beta thal patient who at day -16 was admitted for a surgical procedure and received transfusion to reduce the percent S and to improve her chances of not developing acute chest syndrome or other things after the surgery. She was discharged after the surgery and then presented to the hospital on day 0, now with a hemoglobin that was much lower than her post-transfusion hemoglobin level and a spike in her LDH. Okay, and the other thing that you'll see is that the hemoglobin, although it went down, the degree of reticulocytosis did not appear to go up in relationship to the decline in hemoglobin. So this is a point that Susan talked about earlier, where you get a relative reticulocytopenia. So relative reticulocytopenia below that level where compared to where the patient lives, that could be a sign that somebody's having a delayed hemolytic transfusion reaction. And look at the immunohematology studies. The DAT is initially negative, and it's not positive till later. and this patient's antibody screens were negative. Okay, so it may take time for some of these things to pop up, because if a patient has circulating antigen-positive red cells in their body, and it takes time for the immune system to start producing these antibodies, they can be in a period of relative antigen excess, where you have so much antigen-positive red cells floating around from the transfusion that you sort of absorb a low titer alloantibody out of the solution, and you can't really detect it on an indirect antibody screen. And it may be so low in titer early on that you don't really, even though you have a positive DAT, the eluate where you try to take the antibodies off can still be negative. So it creates a very confusing and very difficult to interpret immunohematologic picture. And so in this case, they did give an additional red cell transfusion, but pretty soon after that, it was recognized that the patient was probably having delayed hemolytic transfusion reaction, and they left the patient alone. And the hemoglobin sort of stabilized. There was some improvement in the reticulocyte count, and then the LDH went down afterwards, and the patient was subsequently discharged. And I think that's my final slide.
I have a question, Min. So can you talk a little bit about I know UCI has this and other hospitals. Most places that see sickle cell patients have a protocol for what type of blood you should give a sickle cell patient. Can you talk about that?
Sure. A lot of this comes from Oswaldo Castro and his work at Howard University a couple of decades ago. And what Castro did was looked at his population of sickle cell patients and looked at the number of antibodies that the responders made. So not all sickle cell patients become alloimmunized. It looks like there's a population that he has referred to as responders that tend to be more likely to make alloantibodies. And among those responding patients that had antibodies, he looked at all of the alloantibodies that they made, and then he put into a computer model, and he said, well, if we balance the percent of alloantibodies that could have been prevented by giving antigen-negative blood or phenotypically matched red cells against the difficulty of procuring more, progressively more well-matched units, where is the break-even point? So when you get to about RH and KEL, maybe you can prevent about 87% of alloimmunization in his data set, but you still have a degree of antigen matching where it's realistic to fairly readily procure units that are RH and KEL matched. The minute you start adding additional antigens to the RH and KEL, like Big S and Duffy and KID and all this stuff, you start entering a territory of progressively rarer and rarer units, and it becomes practically very difficult to maintain upfront extensive phenotype matching. Okay, so the break-even point that RH and KEL looks like it comes from, that Oswaldo Castro paper, and many places will start off with RH and KEL for the non-alloimmunized patient, and then the minute the patient starts making antibodies, then they start increasing the degree of phenotype matching after that. And obviously give units that are negative for the antibodies the patient is making.
So I've had the experience of patients not being well matched, getting random transfusions, having 5 to 6 antibodies and no blood available when you need it. And that is a big problem. So that's another reason you don't just transfuse for a hemoglobin of 7 or less. I mean, it's a problem.
Yeah.
I think we need the next slide, Mike. Is that?
Yeah.
So let me just talk about this slide for a second. So Min basically gave you the whole perspective, but what do you do as a clinician when this happens, So patients can present with pain and fever and a drop in their hemoglobin below their initial, what they started out with, which is called bystander hemolysis. If you transfuse them, it makes it worse. You cannot transfuse these patients. You can try steroids. We've done Procrit, we've done steroids. I'm not sure any of that works, IVIG. You just sort of have to wait it out and have them in bed rest. And you just have to wait. So it's very scary. I've seen people go down to a hemoglobin of 3, but eventually they come back. Okay. Next slide. So I think we talked about this. Just, Min talked about calling the previous hospital. I've seen people who have been hospitalized a year or 2 ago and developed antibodies after that, and then you can't find them. So you always have to call the last hospital, even if it's longer than a couple months ago. Next slide. So I think this is our summary, and then we'll ask if anybody has any questions. So sickle cell patients should not be transfused, just for acute drops in their hemoglobin, especially when this drop is accompanied by fluids, they have an adequate retic count, and there are no symptoms related to the anemia, and pain is not an indication for transfusion in any case. You can use Procrit in patients with renal failure, but you have to use a larger dose to overcome the hemolysis. And iron overload is a very significant problem. You cannot just, you're seeing a patient acutely, you want to make them better, and then you get them out of the hospital. Well, if they don't have any place to go to follow up, that's a big problem. So that's a really important reason why we should not be transfusing patients without thinking about it. And then good communication between blood banks can help avoid delayed transfusion reactions. So that's basically our talk. Is there anybody who has a question?
So remember, there are quite a few people that have their mics muted, including, I know that Children's Hospital in Oakland has the mic muted. Anyone there, nod your head if you would like to chime in or ask any questions.
Oh, Min, there's your kid. This is like the guy on the YouTube video.
He's photobombing.
Maybe he has a question. No, okay.
Also, UCI staff, we have you still on the line. So if anyone has a question for the full talk, now's a great time to chime in.
Oh, here comes somebody. Okay. No?
Yeah, looks like.
No, I don't think we have any questions. Do you guys have any questions over here? No.
Okay, thank you.
And then I want to catch one more time. So Oakland Children's Hospital, you guys are muted right now. Do you want me to unmute so that way we can speak with you? I'll go ahead and do that really quick, and then you can tell me no.
Okay.
Yeah.
Everyone nod.
Yes, we're good, and the hospitalists thank you for the recommendations for the Dose for All treatment while inpatient.
Oh, good. Okay, that's a great idea. Okay, good.
We are on it. Thank you.
Oh, sure.
One thing too, Susan, it looks like we have Brooke Cook from Phoenix Children's. Brooke, I'm wondering if you guys have any other, if it's just you on the line, or if you have anyone else from Phoenix Children's that's on the line.
It's just me this month, and then the person who's training for me went on maternity leave. But as far as last month, I know we had a very large number, so just me today.
Okay. Thank you.
Well, we'll see you in Phoenix, so,
Any other questions from the group? We have quite a few other people that have called in, and I wonder if any questions for Dr. Tran or for Susan.
It's remarkable to me how challenging some of these cases and how complex they can get. And I would encourage you, if you have any of these complex cases, to utilize your blood bank specialists at your local hospitals or your blood reference centers. We've had a couple of cases recently where we've had to reach out to colleagues all across the country and get opinions on what to do.
If you encounter a donor or a patient like that, it may be worthwhile to, if it's possible, if they have siblings, you may want to have the siblings typed, because it may be possible that they may have a similar red cell phenotype. These would be the cases where you might think about molecular phenotyping the recipient or the patient. Also, it's probably unlikely that a really active sickle cell patient would be able to muster an autologous transfusion, but if it's possible, well, actually the problem, in healthy individuals, this is the other problem you get with sickle cell anemia. In healthy individuals who have a rare...
Oh, man, you cut out just a little bit.
Yeah, you're frozen.
All right.
We lost you at healthy individuals.
Wait.
Okay, so is that better? So in healthy individuals, who have a rare red cell phenotype, they can provide autologous donation, and you can store those either as liquid or cryopreserved units. But the problem when you get to a sickle cell patient is that you cannot store their blood. Their blood does not pass through the leukoreduction filters very well, and so you end up with filter failures, and it also does not cryopreserve, and you can't deglycerylize it on the back end. So these are really tough transfusion circumstances, and I think our colleague who mentioned nationwide searches for antigen negative units, that can definitely be the case, and it can be really tough. So I think that's part of the message for today is every transfusion potentially holds the risk of additional alloimmunization for these patients.
And iron.
And iron, yeah.
Yeah, which isn't trivial either. So
that's scary. Well, thank you, everyone. I think there's one big thing, one big ask that I think we can all appreciate. So we definitely take attendance on these calls. One of the things that is a little tricky is trying to get your attendance whenever there's a large group in the room. A huge favor to me would be if someone in the room could take attendance and let me know who all I'm speaking with. Mostly with the UCI group, I know there are quite a few physicians in the room, and so if someone could take attendance, I spoke to Dr. Steven Zhao. If he could just forward me through a list of those providers, that would be wonderful. Just that way we know who is on the call. In addition, these calls are monthly. And so we have these calls monthly. We will put you on a call list, so an email list, in order to know that the calls are coming and to be able to see what is coming for the next call. We have a meeting, so the PSCRC has a meeting in June, and so we'll be doing part of our ECHO work in June, and so they may not be, the talks themselves may not be public, and they may not come to you in public, but they will be put on our archive. So we have an archive that is set up with the Center for Inherited Blood Disorders. So anyone wanting to see these backlog talks, we keep the didactics online. So you can go back and watch them. They're just a YouTube video, so they're easy enough to watch the didactics. There's some great material on there right now. There's a talk on TCDs that is wonderful. There's a talk on pain and sickle cell disease that is equally great. So we're banking these so that way there's a great educational tool for people. All it requires is a simple registration. That registration is helping to put new people into the calls and keep you informed as to what we're doing. So we appreciated anyone to register for that. That would be wonderful. And that'll come out with an email that'll go to the group. So that's something that you'll absolutely see the link, and I'll highlight it and try to put as many exclamation points around it as I can. In addition, we also ask for evaluations. So we will be sending out an evaluation at the end of this call. It'll ask you some basic information about what you knew before the call and after the call, and a little bit about what you're interested in, what you would find interesting for the future of these talks. So with that being said, please complete those evaluations. We really, really bank on those to help us inform what we're doing next and how we're doing. I think that's about it. So I think with that, thank you very, very much to our two presenters. We want to thank both Susan Klaster and Dr. Minha Tran. We greatly appreciate your work and the aid that you gave us today in this educational talk. Thank you, UCI, for letting us in. Thank you, BCHO, for bringing the group of providers that you did. And thanks, everybody, for coming.
Thank you.
Thanks. With that, we'll go ahead and sign off.
Okay, bye.